Hi, I'm Dr. Joseph Wood-During, and today I wanted to talk about how the dysfunctional medical system can lead to something called prescribing cascades. Um, so what is a prescribing cascade? Prescribing cascade is when someone comes in with something that's relatively benign. Let's say that they're depressed or anxious because they're going through a divorce or they lost a job or something like that, and then they get started on a medication, and things snowball, and then they have side effects to that problem. They get another medication, they have more side effects, and eventually they end up on like 5 different medications, and they're just a mess. And so this is what we do in our practice. We untangle prescribing cascades, and so we talk to a lot of people about, I guess, how they started, and I'm going to share my perspective on this topic. And so our medical system is kind of set up in a way, especially if you're going to the kind of insurance-based system. It's set up in a way where, I guess, the physicians that are seeing you have a lot of different incentives. I think doctors, they go into the profession, they want to help, and that's kind of, I guess, I don't want to say naive, but once you kind of see the way medicine is practiced, it can be very different. So, so why is this relevant? Physicians can be incentivized to see more patients per hour because they get a higher payout from the insurance company. So, if you're a psychiatrist and you do, 4 15-minute visits in a session, as opposed to say, a 15-minute like med check plus, an add-on of like maybe, 50 minutes of psychotherapy. Although they're like roughly the same amount of time, you make way more money by doing the 15-minute med checks. That's just how it's reimbursed. The insurance system and the way billing and coding is done, it's not set up in a way that I guess encourages a lot of therapy, especially for prescribing physicians. It kind of incentivizes them to just do an evaluation for 15 minutes and move on. And so, why is this a problem? Like, obviously, you don't get that much information in a 15-minute appointment. And so then what do you do? And I guess what a lot of people do is what leads to prescribing cascades. So you have someone that comes in, going through a divorce, something bad is happening in their life, and they get started on an antidepressant. This is a good one. And then they take that medication for a while. Maybe they've been on it for about 6 months or something, and then maybe it's working, they're not really sure, something else is happening, and they go up on the dose. Shortly thereafter, they become very agitated, and they end up in the hospital because they're really irritable and their family is worried about them. And then the physician who evaluates them, again, only kind of, they're in the emergency room, they've got a million other people to see. They want to just kind of figure this out pretty quickly. Oh, sorry. Okay, so you're in the emergency room. You get sent to the psychiatric hospital. And if any of you have been in some of these county psychiatric hospitals before, you don't spend a lot of time with your physician. I would say on average, maybe it's like, 20 to 30 minutes for the intake. And then for like the follow-up visits while you're there, it's like 5 minutes. So anyway, you go in there, the physician just goes, you know what, if I can, see these, 10 people before noon, I'll take off and I'll go home, and then I'll just, respond to any calls, from home, because, there's not a big incentive to spend, 2 or 3 hours with someone, that's going to start eating into their time with their family and things like that. Okay, so they come in, okay, yeah, you're on this antidepressant, and you, okay, now you're agitated. Instead of even like going and doing that history and just saying, okay, tell me about your background. When did when did this happen? When was it in relation to your medication changes? Okay, maybe they don't know that antidepressants can cause mania, and they go and they pull up the drug label and they look at it and they go, okay, that's interesting. But instead of that, they go, okay, well, he's agitated and he has depression and he's in his early 20s. Oh, this could be bipolar disorder. The most conservative thing that I could do right now is to put this person on, let's say, some Depakote. This antidepressant may have unmasked some bipolar disorder, and so without taking a history, they just grab the person's clinical symptoms, diagnose them with a new condition that fits, and write a medication. And that's like a lot easier than taking a history or calling their family and getting, collateral information of, what happened when you see these changes. Tell me about your, what the patient is like normally. So a lot easier to just, okay, symptoms, it's bipolar disorder. Let's throw another med on there. Okay. Now this person's out there, maybe they're on Depakote and they're having difficulty concentrating at work, and maybe they go to a place that doesn't do a very good job. They go in there and, they say, I'm having difficulty concentrating again, without kind of going through this process of saying, tell me about where this emerged from. Not all doctors, but some of them, they might start them on, say, a medication for ADHD, whether it's Strattera or maybe an amphetamine medication like Adderall. And so now you've got someone kind of on these two different medications that they don't really need to be on, and then life happens. Someone may all of a sudden run out of that Depakote one day, and then they start having withdrawal, and then they go back into the hospital because they're suicidal and they're really irritable because they're in withdrawal from Depakote, and then they could kind of get an antipsychotic thrown on top of that to cover it. Again, it's the same thing. Someone doesn't kind of look at the history and how these medications started and how the symptoms are related to the temporal course of the medication. You can also have someone, get started on this ADHD medication and now they develop some paranoia or maybe even some hallucinations in severe cases. And then it becomes kind of like bipolar disorder can turn into schizoaffective or something like that. And so you can get these cases where, you have these people and they're on like 5 different medications, and it's just a mess because the initial problem was something that may have just been contextual, and now they've kind of been chewed up by the system and spat out because everyone was incentivized to see the patient in the shortest amount of time, and they didn't do a really good job, and it's kind of harmed the person for the worse. So that's my perspective on, I guess, prescribing cascades and how that can happen. I mean, sometimes you do bump into good doctors and they'll say, hang on a second, just stop. Why the hell are you on this? But sometimes you don't. And that's when these really bad cascades happen. So did this happen to you? What was your experience like seeing physicians in the public system, with insurance and things like that? Did you have a great experience, or have you seen kind of similar behavior to this where it's not so much interested in your history, the clinical course and all of that, but more just you've got these symptoms, take this medication, see you later. Let me know your thoughts on this. Thanks.